Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a middle-aged man who presented to our ER with complaints of lower abdominal pain and fever.
Okay.
So there's this 65-year-old male patient who presented to our ER with complaints of lower abdominal pain, fever and chills, predominantly on the right side. But then a little more history-wise, he was catheterized 3 weeks ago, and then he was off catheter. So duration of catheterization was for 2 weeks. Following removal, 2 days later he developed lower abdominal pain, and a day later he developed fever with chills.
Okay.
So with this background history, he had presented to the ER. In our initial 10-second assessment, patient was talking, conscious, oriented, obeying commands. So we moved on to the primary survey. Airway patent, patient was talking, comprehending, no secretions was noted. Breathing wise, patient's air entry was bilaterally equal. Respiratory rate was normal, 16 cycles per minute, and saturation was also in room air he was maintaining to 97%. And adequate chest excursions were there, and bilaterally on auscultation, chest was clear.
What are the systemic manifestation of urinary tract infection? You are seeing many urinary tract infection in ER now. Okay. So what are the systemic manifestation of urinary tract infection?
Renal system can be involved, pyelonephritis, hydronephritis, AKI.
Systemic means I am not asking renal system. Systemic means as a whole.
So sepsis, septicemia can be there.
What are things?
Altered
sensorium. Altered sensorium can be due to toxemia, can be due to hyponatremia.
Dyselectremia.
Okay. So dyselectremia and toxemia is very, very common in UTI, especially in diabetic patient. And some patients can have volume depletion due to various other causes. Okay, they are not taking adequate water. Okay. So whenever you see UTI in routine setup, it is only simple UTI. But what we are seeing in our settings, it is a very complicated disease. Okay, they come with severe septicemia, shock, or altered behavior, confusion state, and hyponatremia. Okay.
So circulation wise, patient had a heart rate of 96 beats per minute with a blood pressure of 130/76. And then all peripheral pulses were palpable, warm extremities. Disability wise, full score of GCS, and pupils were 2.5 millimeter, bilaterally reactive. Now moving on to the exposure wise, patient was having a little temperature of 99 Fahrenheit, but that's about it. And GRBS was normal, 142 milligram per deciliter. With this complaints, he had come in, like this was our initial survey. Then for our primary adjuncts, we used a VBG because it gives also a parameter of lactate levels and gives an idea on the acid-base derangement. VBG had a pH of 7.4, PCO2 was 32.6, and bicarbonate was 19.9. So no much acid-base derangement, and lactate was 0.9. Then ECG was also taken, and it showed only sinus rhythm, no other abnormalities were noted.
All electrolytes are normal.
Now in electrolyte part, sodium was slightly on the lower range, 120.4, but potassium was 120.4, and potassium was 3.6.
Okay. What do you think about this electrolyte imbalance?
Patient also had elevated creatinine. So possibly creatinine, renal loss, hyponatremia can be a cause.
Okay.
And
in a renal failure patient, when the kidneys are affected, like pyelonephritis, patient can lose all electrolytes through the kidney. Okay, sodium, potassium, calcium, phosphorus, magnesium, everything can lose through kidneys. Okay, that is a problem of UTI.
So patient was found to be hyponatremic and had elevated creatinine. So AKI was suspected because this patient was not known to have CKD related issues.
Okay.
So this was just the primary adjuncts. Now moving on to the sample part of the history.
How do you know that it is CKD, not acute renal failure?
Anemia in chronic disease we can find out. And baseline creatinine we can ask the patient.
Previous creatinine is available, that is well and good. Then you can do
USG corticomedullary differentiation.
Then anemia like then one more thing. Hypocalcemia, hyperphosphatemia, and retinal changes. Okay, so if possible, all of them should be done to rule out renal failure. Otherwise, in simple way, how do you make out? Simple way is give fluids or give the treatment. If it is reversing, then mostly it is acute renal failure. Like if it is due to dehydration, then give fluids and you can see the reversal. If it is due to acute infection, after giving antibiotic, it may revert back. That takes time. But acutely, like you told, these are the simple lab investigation which may detect whether it is patient is already having CRF or acute on chronic renal pain.
Renal failure. So, moving on to the sample history, he was known to be only diabetic and had an old CVA history about 9-10 years ago. So, he was on dual antiplatelets and injection mixed, human mixed.
Okay.
That's about it. No other medications that he was on. So, what had happened is 3 weeks prior to the arrival to our hospital, he had acute retention of urine, possibly BPH, but we have no details that can confirm that diagnosis. So, he was catheterized. So he was put on Foley's catheter for about 2 weeks, and then following removal, 2 days later, he developed lower abdominal pain, went to a local hospital where he was symptomatically managed. Then a day later, he developed fever with high-grade fever with chills and worsening abdominal pain. So USG detected outside just showed cystitis.
After removal of the catheter, does he had a good urine output or not? That is very important.
He had difficulty to pass
Passing.
urine,
So
and when
mostly
he passed,
again
it was
obstruction might have increased.
and while passing also the output was little less. So that was his urine complaints. And then when he visited our then outside itself ultrasound was done.
From your point of view, somebody come with prostate enlargement, what are the drugs can precipitate urinary shutdown in a patient who is having prostatic enlargement? What are the drugs we use in emergency room can produce acute urinary retention?
Anticholinergics.
What drug? Atropine and even atropine, glycopyrrolate and nebulization of hypertropium bromide. Okay. All these drugs can acutely precipitate urinary retention. The patient is already having a BPH. Okay.
So
This occurs mainly in organophosphorus poisoning. So elderly individual coming with organophosphorus poisoning. Unless until you have a catheter, you should not try to give atropine in a higher doses, because they'll definitely develop acute urinary retention.
So outside ultrasound was done, which showed just bilateral renal calculi, but it was documented as non-obstructive.
How do you know that it is
cystitis.
non-obstructed from ultrasound report?
Hydronephrosis.
Hydronephrosis. If the hydronephrosis is present or hydroureteronephrosis is present, then it is obstructive. Okay.
And that was not there, just mild hydronephrosis what was documented, and no signs of pyelonephritis.
Okay.
And then the patient, in view of persisting symptoms, presented to our ER.
Okay.
So
Can simple urinary tract infection produce hydronephrosis?
yeah, if there is reflux.
Sometimes cystitis produces inflammation of the tract, can produce same mechanism like you have a stone. Patient can have hydronephrosis. So some patients with simple, not simple, complicated urinary tract infection can have hydronephrosis. But once you treat that, it will completely relieve. Even in stone, sometimes after dislodgement of stone, you can get complete relief of that hydronephrosis. Okay.
So in our, since he was in little pain, we had a pain score of about 3 to 4. So we gave him an injection, paracetamol 1 gram for his pain.
When you treat a urinary tract infection pain, you should know what type of pain it is. Is it a continuous pain or colicky pain? What type of pain it is?
Colicky, if it is ureteric calculi as the cause. If there's no calculi and it's just this, then it will be continuous.
Okay, so how do you treat both? Is it like somebody is having colicky pain, treatment is different. Somebody is having a dragging pain, treatment is different.
So if it is a colicky pain, then it is possibly secondary to calculi and it will be intermittent. So at that point in time, drug of choice is NSC8.
No.
Antispasmodic.
Antispasmodic is the pain treatment. Okay, if there is obstructing and producing hydronephrosis and dragging type of pain, then you are told NSAIDs should be avoided. If there is renal failure, paracetamol can be given. But if there is a spasmodic pain, antispasmodic drugs like Buscopan, okay, that should be given. Okay, so we have to be very careful. We have to analyze what is the type of pain. Okay, in the spasmodic pain, if you give NSAID, nothing will happen. It will not change. Okay, that's why most of the tablet contain you have meftalspase, that is mefenamic acid with antispasmodic. Okay. So you have to give both. Some patients will get relieved with your simple NSAIDs or paracetamol because it's only an obstructive pain.
So, since his creatinine was elevated and he complained of decreased urine output, and also we had to hydrate the patient, so we put the patient on IV fluids. In the meantime, we sent for blood investigations. Now that CRP was elevated to 164.2.
Can you tell about flush therapy? What is flush therapy?
Flush therapy is when a patient has basically for an intervention of a calculi, it has to be minimum 10 mm. Then lithotripsy, interventions will be done. If it is less than 10 mm, then when you hydrate the patient, then the patient will be able to pass this calculi through the tank.
You have to give alpha blockers. You have to give along with that alpha blocker also has to be given, so that stone will be flushed out. Okay.
So
flush therapy can be started from ER itself. Okay, any patient who is having stones, who is not going to undergo a procedure, you can start fluids with tamsulosin so that it will be flushed out. Okay.
This patient was already put on Silodol, sir.
Okay, Silodol.
Silodol, he was already put on it from a local hospital. Okay. So then we hydrated the patient. In the meantime, sent for blood investigation. CRP showed 164.2, and total counts was 9,370. Then RFT was deranged with urea being 70 and creatinine being 3. And he was not previously documented to have CKD, and hemoglobin was also around 10.7. So we had sent for an anemia workup too, and along with this, considering it as a pre-renal failure, hydrated the patient, and we did a bedside ultrasound. And ultrasound suggested cystitis with features of pyelonephritis bilaterally, but predominantly on the right side. So then we sent for a CT-KUB. Now in CT-KUB, it turned out
contrast
there was
or non-contrast?
CT-KUB plain. Contrast could anyway not be done because of creatinine elevated. Plus, if it's a calculi, then CT-KUB plain is good enough. So when we sent the patient, then report came out to be right-sided pyelonephritis with calculi of 7 mm obstructing the pelvic part of the ureters. So it was obstructive calculi causing hydroureteronephrosis. Along with this, he had AKI and cystitis with bilateral pyelonephritis predominantly on the right side. So this was the picture. So at this point in time, we started on IV antibiotics and empirical
what
therapy.
What antibiotic you prefer?
Considering this as a complicated UTI with a background of patient being diabetic plus male patient and recent catheterization, it was a complicated UTI. So we started the patient on piperazine and tazobactam. If it's a simple UTI, it will be even fluoroquinolones will be good enough. But this is like an empirical broad spectrum therapy. We started with Piptaz. Then following
you think
this,
that fluoroquinolone will not be effective in this case?
Complicated UTI. That
it is equally beneficial. You see, President Tazobactam, if you take levofloxacin or moxiflox, whatever it is. Okay. What is the difference? Basically, what is the difference in urinary tract infection?
It will be predominantly gram-negative coverage.
This will cover gram-negative. Only if the organism is resistant to ciprofloxacin, then only it is not effective. Otherwise, they are equally effective as piperacillin tazobactam. Even if it is ESBL, it is effective. Okay. So urinary tract infection, always first line of drug is always fluoroquinolones, even if it is complicated. But you can only answer like this patient has come from another hospital. So there is a high chance of hospital acquired infection that most of the time they are quinolone resistant. But if it is a community acquired infection, urinary tract infection, quinolones are equally effective like your piperacillin tazobactam or meropenem. Because whatever you are seeing organism, including ESBL, it will be covered by fluoroquinolones. But only disadvantage is it's a hospital acquired infection. Possibly he developed all the complication after a catheterization. So there is a high chance of hospital acquired infections.
So IV antibiotics, Piptaz was started, and along with that, supportive management.
What is the dose you have preferred?
We had to make it as a creatinine clearance will be there, so we'll have to check for the creatinine clearance.
First dose?
And then First dose will be 4.5 grams.
So first dose is always same as any other dose. Second dose onwards, you
clearance has
go
to be-
according to
creatinine clearance and daily monitoring of creatinine, and
Okay.
we
Adjust
adjust the dose accordingly.
Okay.
So this was started. Then along with this, hydration and urology consultation was placed in view of obstructive uropathy.
Okay.
So he was planned for degestenting, and post procedure patient period was uneventful. And at this point in time, procal had also come in, which was elevated, and blood culture reports came in, and blood culture showed growth of budding yeast,
Okay.
and urine culture report suggested Candida tropicalis. So this was a candidal cystitis causing candidemia.
What are the risk factors for candidal cystitis?
Immunocompromised state, diabetic patients,
Okay.
malignant,
Malignancy,
neutropenia. Basically, this immunocompromised patients and advanced ages.
Okay.
So this can be. These were the, and he
So here
pretty much
diabetes
is
is the cause.
diabetes, uncontrolled diabetes. His HbA1c came up to be 8.8.
8. Okay.
So, this, and then in the cultural sensitivity report, he was sensitive to both amphotericin B and fluconazole.
Okay.
So, but amphotericin B, the liposomal amphotericin B has more. Previous trials have shown to have more adverse effects.
Okay.
It causes hypokalemia, hypomagnesemia. Along with this, distal renal tubular toxicity will be there, and this patient was anyway in AKA.
Okay.
So liposomal amphotericin B at this stage was not an ideal choice.
Okay. Amphotericin B is not an ideal choice. Liposomal amphotericin can be given in renal failure, but still it can produce electrolyte imbalance, like told, it can develop hypokalemia. So that is one of the major side effect of amphotericin, liposomal amphotericin B. Amphotericin B cannot be given because your kidneys are damaged. Now. Okay.
So fluconazole could have been given, sir, but the patient's septicemia was moderate to severe. So in that case, we will go ahead with a stronger.
Fluconazole is mainly a locally acting drug, not a systemic acting drug. If it is in the lungs or urinary tract alone, we can give. But here the patient has developed sepsis. Okay, so fluconazole is out of question here.
So candidal septicemia patients. So we started on echinocandins.
Okay.
And echinocandins, the available options are caspofungin, micafungin, and anudilafungin. In this, we chose caspofungin.
Okay.
But
is
all
there
the
any
three
difference in all the three? Separate, like if you take one drug, is there any major difference?
There isn't any, because all the three have similar efficacy.
Similar action, almost similar action. Mild variation in other side effects maybe.
And patient tolerability is better with echinocandins in contrast to amphotericin B.
Okay.
And adverse effects are also very less. It can cause hypotension, diarrhea, nausea, vomiting, but it is not very predominant as it is in amphotericin B.
So which one you selected
So
here?
we chose caspofungin. So caspofungin we give as a dose of 70 mg. We give on the first
Loading
day.
dose.
Loading dose. The next day onwards we give it as 50 mg once daily.
Okay.
And then we repeat the blood culture and sensitivity after about 3 to 5 days. And then if at all culture sensitivity report has come back to be negative, we continue or we'll taper it down to oral fluconazole.
No. Even if it is culture negative also, you have to continue the treatment for 14 days. Here why we are doing repeat tests is you want to know whether the organism is coming down with your treatment, that's all. Okay. You are not going to change your treatment options on basis of culture. Okay. You have to continue the same treatment because it's a fungal sepsis. Okay. Even if you are not getting in the blood, it can be there in everywhere in the body because patient is in immunocompromised state. So minimum duration of same treatment is 14 days. Then only you can switch to oral tablets.
So this patient is currently undergoing treatment with caspofungin along with this peptide combination therapy, and then his repeated creatinine and infective parameters are all coming down. And during his course of a stay, he had one episode of he had stool occult blood to be positive, and then he had an active bleeding PR. And we took the patient for sigmoidoscopy, which showed sigmoid colon ulcer. Now that has not really been evaluated more, as the patient is currently not in a state to be
Okay.
taken for further procedures. So, if possibly malignancy has to be thought of because of fungal septicemia and his immunocompromised state.
Okay.
Um,
Now,
then
what has to be done for the patient for the ulcer part?
ulcer part, uh, what was planned was a CT angio with embolization, but
Since there is active bleed, we have to do embolization.
embolization, but because the patient had AKI, angio could not be done. So at a later date, sigmoid colon resection has been planned.
Okay.
So possibly biopsy from that resected colon has to be taken and evaluated for any malignancies.
Okay.
And as far as prostatomegaly is concerned, PSA was sent to rule out any prostate malignancy also.
What
but
happened to PSA?
PSA is normal, sir. PSA is
How
fine.
much?
1.8 or something. PSA is fine, sir.
Okay.
PSA is normal. It falls within the normal range, 1.8 or 2. 1.88.
Okay. What is the normal range of PSA?
Up to 4.
Up to 7, you can take it as normal. 6, 7, you can take it as normal. If it is BPH, it will be in that range, 7 to 10. Okay. More than 10 only, you have to suspect malignancy. That too, when urinary tract infection is there, always PSA will be slightly higher. Here, it is low because prostate is not involved. It is a higher up infection. Okay. So if there is active urinary tract infection, when the PSA is high, it can be attributed to the infection part. Okay. So ideally, when the patient is completely recovered from the infection, we have to ask PSA. Here anyway it is low, so we are not suspecting anything else.
So, and because of the underlying sepsis and also his uncontrolled diabetes, glycemic control has to be given. And then a patient was initially bedridden too because of the pain and his septicemic condition. So DBT prophylaxis should also be given.
Okay.
And he was anyway on antiplatelets.
Okay.
And then DBT.
Now, how you control the sugar? What was that?
Sir, in our
insulin
ICU,
requirement?
we did it as human actropid was given. And initially, we just kept a dose of 8 units TID. And then, depending upon his sugar levels, we adjusted the insulin, and we kept a target to have between 140 to 180. So, at present, he is having a dose of 15 international unit TID.
So will you see the blood sugar level and give additional dose, or you increase the dose slowly every day? What is the correct method?
We see the trend and we increase.
Some physicians see the blood sugar and give additional dose. Some physicians see all the blood sugars and increase every day's dose, total dose, which is correct. That is, other one is called as sliding scale method. Okay, it is not scientific. After increasing the sugar, you are intervening. That is not a correct strategy in ICU. ICU strategy is increase the insulin and make sure that sugar is not increasing. Okay, so you have to ideally give previous dose has to be increased. Okay, so you have to see what is the total dose given today. If it is not getting controlled today, tomorrow you have to increase the dose, or next dose has to be increased. Not seeing the blood sugar and titrating up and down. That is not a correct method. Okay, that is called a sliding scale method. It's not a correct strategy, especially in ICU patients. What it is, okay.
So his sugar levels were brought into control. Infection, IV antibiotics is given. As far as his calculi was concerned, degestenting has been done.
Any other blood investigation you want to know? Want to do to rule out the causes for the stones?
Uric acid has to be
Uric acid
done.
and calcium.
Calcium
So that
levels.
should be done.
Calcium was normal. Uric acid was also fine only. Uric acid was little elevated.
How much?
It was little elevated.
So uric acid is very important. Okay, how do you manage? It is elevated.
Since it's not an acute, febuxostat can be started. So febuxostat you can start at 40 mg and then see if it is not controlling the uric acid, you can hike it up to 80 mg.
Here, if the uric acid is high, no need to start colchicine. Colchicine is a drug to be used in uric acid induced gout, arthritis. inflammatory condition. Here it is not like that. Uric acid is producing a stone. Okay, it's a long-term chronic process. So you have to give some drug which can continuously reduce the uric acid. But only when you are having a stone, you are giving uricosuric drugs. What precautions you advise the patient?
Plenty of water.
Yeah, they have to
Hydration.
take a lot of hydration. Otherwise, this uric acid will go and accumulate in the kidney or down. It produce further calcium stones.
And following the control of infection and also calculating stenting intervention, his creatinine has come down. Like it's consistently coming down, and his infective parameters are also downtrending.
Anything else you want?
What is the CBC?
Latest of the first
Platelet
is,
count and other things.
so the total counts is 9,370, platelets 1,90,000.
Okay.
CRP was 164.2. Initially, the second day and all, it was increased until we started fungal antifungals. It was increasing like 210 range, 20 range. It was increasing every day. So after we added antifungals, then it was downtrending.
Anything else?
No, sir.
Okay, thank you.